Okay, so there will be, as we will go through these lectures, there will be a lot of overlap between different speakers. So, if anything, and it may improve. So it's not really redundant. So I'm going to pass through them really quick. So, thing is Darwinian self-selection is we were introduced by again James to Bill Lombardi, who inaugurated this 4 years ago. And he said, and this to us as well, he said, if it ain't fun, it ain't fun. If you do not attempt to conquer, you will never will. And chance favors a prepared mind. Number 4, always show your superior judgment so that you don't have to show your superior skills. So there are a few words of wisdom by Bill Lombardi, apparently it's from his father actually. So what are the checklists? Number 1 is planning. I go again a few years ago when I first met James here in Bahrain. It was really one of the unpleasant experiences I had. Because we had different people coming to teach us and train us, and then the first thing he said on a Saturday morning, where is your plan? I said, well, we're just going to wire this and we'll do that. And then he said, sit down here, get me a piece of paper and write your strategy. So then at that time I only had one strategy in my mind, and actually he was mad, and I said, who is this guy in my lab and doing this to me? But with that I learned quite a bit. Planning is extremely, extremely important. You sit down, review the angiogram, look at the prior angiograms, look at the CTAs, assess your patient, know your patient, and get the consent. The consent for these procedures are different than the usual consent because, as we discussed and we will be discussing, the rates of complications are higher. So Dr. Hill has gone through all of this in a lot of details. I'm going to skip through these because occasionally angiograms could be very, very misleading. If you look on the image on the left, you see the LED CTO. It may look a long CTO, but actually, if you do a dual injection, it's actually a very short lesion that you can finish this case hopefully within a few minutes. Again, reevaluating the angiogram, look into these 4 essential components, the proximal cap, the lesion length, the landing zone, the collaterals. It's essential way to look into the C2 analysis. So scoring, Dr. Hell went through, explained to us the Cto Score in details. Essentially, this would help you to determine your success rate. So my piece of advice that I want you to go away with it is that do that on a regular basis, and when you start your program, don't start with a Cto Score of more than 2 because you tend to fail, and then once you fail, it would deter you to do more, and it would give you really negative emotions during doing these cases. So start and build your skills in the Cto Score 0 to 1, and as you go on with the experience and skills, you can move on further up. There are other scores, such as the progress score, and the reason I'm showing you, because you need to combine all these analytical findings on the scoring system, then you can come and you can determine by yourself the complexity of these. For example, the progress CTO score, which is essentially different than the other ones, it puts in 2 other things, which is the circ. And we know that circumflex artery is typically more difficult to intervene in CTO patients. The other thing is they have also put in this score is the usage of interventional collaterals. So if you have interventional collaterals, the cases tend to be easier. If you don't have interventional collaterals, the cases tend not to be easier. And the major reason because of that, you are limited with your approach and the strategies. So when you have a chronic hotel occlusion, you have to think about the risk and benefit of your patients. What are the benefits? We talked about it already. You always have this in the back of your head. What are the likelihood of success? And then you can determine that by using the Cto score or the progress Cto score. And then you always have to think about the risk. What is the risk to this patient? What is the risk of restenosis? What is the risk of thrombosis? What is the risk of mortality during the procedure? Because these complications, when they occur, they're not trivial complications. There could be major life-threatening complications. So you have to really assess the risk and benefit when you offer this to your patients. Jonathan did talk about the CT. CT has become has more role these days in the analysis of your lesion, and it helps to show your length, your calcification, and occasionally helps you actually to find out and solve the issue of proximal ambiguity of your lesions. So CT is coming up and being used intensively nowadays. Also, there is a way you can assess the complexity of lesion by CT scoring system. And all what it does is basically telling us, sorry, it was skipped. It's telling us that when you use this scoring system, would tell you how complex these cases could be. Another scoring that came up from the EuroCTO club is called the EuroCTO Cto Score. And the difference between the other ones, it incorporates post-bypass patients. So added to the complexity, circumflex is more complex, post-CABG patients are more complex, and an advanced age group are also more complex. So age and post-CABG and circ, these are added things that you have to think about when you look at the JCTO score, which is the traditional scoring system has been. Then you need to have your team support. Extremely, extremely important, and team support is from your nursing staff, from your doctors, from your referring physicians, from radiation protection, contrast, and an efficiency of your lab. You need to have the CTO cart in which you don't need your staff to run between labs to get you the equipment that you need. You have somebody to monitor your ACT. We talked about the contralateral injections. We talk about hemodynamics monitoring, your radiographer regarding radiation safety, and so forth. Also, for example, the nurses on the floors to assist for the hydration, pre and post hydration. We occasionally use in our center renal guard if we have an advanced renal insufficiency. Minimize your injections, radiation, decrease your frame rate, use fluoro more than the cines. Very, very, very important in terms of thrombotic prevention. If you're doing an antegrade case, achieve an ACT above 300. If you're doing a retrograde case, achieve an ACT of more than 350. And what happens is, occasionally what we do is we have a venous access on the side, because I'll ask one of the nurses every 20 minutes, tell us what the ACT is, and you have a port, and she or he will go and pull up the blood and do the test without even us as an operator. When you're so much into focus in the case, you tend to say, well, I'll do it after a minute, I'll do it after 5 minutes. No, have an access there if you have it, let them draw the blood, and do it in 20 to 30 minutes regularly, because thrombotic complications are potentially very fatal, very problematic. So dual injection, I'm going to skip through this really quick because it's been really covered by Dr. Jonathan Hell. Another key concept is never follow with an equipment if you don't know where your wire is. If your wire is not in the vessel architecture, don't follow it with an equipment because you get into trouble. The contralateral injection helps you to visualize where you are, efficiency of procedure, and the safety of your procedure. We will come through this. Trust, if you don't know where you are, trust the knuckle. Knuckling is a very good tool to have. You need to know how to do knuckling, and if you see in these two examples how you start doing the knuckle, and the knuckle will actually help you solve the ambiguity of the course of the vessel. So knuckling is safe, and it would help to help you understand where you're going. So this is an example from James iBook. And if you don't know the course of the vessel and you start poking with the stiff wires, you may be out. So however, you can actually do a knuckle, and we'll talk about knuckle even more later on, and you can solve this ambiguity, maintaining the vessel architecture. The issues with the knuckle, occasionally when you do knuckling, you may go to side branches, and then again you need to come and pull back your microcatheter and redirect where to knuckle. An example of which is here, which actually it knuckled into the RV branch. We pull back the microcatheter, take a stiffer wire, puncture into the RCA proper, take the microcatheter down there and go back with the knuckling. And we'll talk about later on in the wire gearbox which wires to use to knuckle. There are specific equipment that have been used in CTO procedures, and I'm not going to go into the details of them, just giving you some highlights. We have to be cognizant about guiding, guide size, guide extension, anchors, microcatheters, and be skillful and know which one to use in which situations. Trapping balloons and how to trap wires into the guide, and which balloon do you use. If you're using a 6 French guiding catheter, use a 2 millimeter trapping balloon. If you're using a 7 French, it's a 2.5. If you're using an 8 French, it's not a 3 point, it's a 3.0. There are dedicated trapping balloons, such as the trapper, in which is one size fits all, and it's really helpful to have in your lab to trap wires in the guides. I think guide extension has made a huge, has helped us quite a bit actually in achieving successful procedures, and why that is important. Guide extensions are important, that it increases your support. It minimizes the length of disease for retrograde wire to negotiate, and actually the guide extension also minimizes or decreases the chance of subintimal hematomas. That's one example where the guide extension is in the mid-RCA. The trap liner is a guide extension with a trapping balloon. It allows using the antegrade dissection reentry utilizing 6 French system. It's a tool that is also available for your usage. Ibis is extremely important. One question that comes up: how often and why do you need to use Ibis in CTO procedures? And I learned that Ibis is very, very, very important. Is to optimize. One is to optimize your stenting procedure, the sizing, assessing the vessels, and also if you have trouble to re-enter, Ibis would help you. So I think if you spend so much time and effort doing these complex procedures, you need to have the best that you can do for that patient to minimize or decrease the long-term effect or restenosis or TLR in the future. Other equipment you may use is the rotational atherectomy, shock waves, lasers, special snares. Occasionally we tend to use hemodynamic support. The ones that we have here is an Impala. Rarely we use a balloon pump, but these are the things that are available for you to use if you have really high risk individuals, single last remaining vessel, or a very poor LV ejection fraction. So another checklist is minimize, very, very, very important, minimize your subintimal space, because if you, for example, when you have a CTO here and you wired it and you went into subintimal space, and this is subjected to systemic pressure, with each heartbeat, this space gonna increase in size, and then it would actually compress the vessel distally. So once you do wiring, minimize your contrast injection. Actually, another trick that you should use, disconnect your injector so that no one even by mistake would inject, because if you have more hematoma, then the chances of re-entry later on becomes much more difficult. There's an example that we did here. It's an ADR case. You can see the landing zone here. We went down with the crossbars. However, I think we had more subintimal hematoma and we lost visualization. And that is one of the problems when you keep injecting or somebody injects for you. So try to minimize injection, because subintimal space hematoma is not a good thing. So some of the terminology that we use is the investment procedure. What do we mean by investment procedure? Meaning if you fail with the style. There's nothing wrong with it if you fail. The question is how you define failure. Failure is, for me, is able to achieve something without hurting the patient. As long as the patient leaves your cath lab safely, that is not considered a failure. So if you have done some procedure and you couldn't access, like the one we had in ADR, call it an investment procedure, bring them back, because many times when you bring them back, as has been seen by the recharge registry, many times when you bring them back, actually you'll be able to successfully recanalize that lesion, more than 87%. But key is when you bring them back within 3 months. Don't wait 6 months, because it becomes like what it was before. Be prepared for complications. Know your skills, how you do it. Have the equipment necessary for dealing with complications. And last but not least, evaluate your own outcome. Extremely, extremely important. With this, I'll stop if there's any questions before we go to the first live case.